here. And let's see.
Looks like it's recording. It's doing something.
Hopefully now should start. So I will make you the host now. Hopefully that should continue working. Okay, sorry to interrupt. Please do continue.
No problem at all. So good. Can you see my slides again?
All good.
Perfect. Good. So what are we talking about? We're really talking about a kind of an innovative, completely different shift in paradigm here. We're talking about a transoral through the mouth, neuroelectrical stimulation for sleep disorder breathing, but most particularly, we're really talking about daytime therapy for nighttime effect. The current need for therapy is 20 minutes per day for 6 weeks, and we have efficacy between treatment for primary snoring and mild obstructive sleep apnea. That's what we're going to be talking about for the next half hour. So you're all involved in this arena of sleep disorder breathing. We're all aware this is a spectrum. And yes, we have certain arbitrary sectioning between primary snoring, mild OSA with this condition, upper-airway resistance syndrome in between, and moderate to severe. I think most of us are very comfortable with treatment of moderate to severe sleep apnea and treatment pathways for that area. But what tends to happen is that in the area of primary snoring and mild obstructive sleep apnea, there is a kind of a lack of understanding and also guidelines and pathways on how best to manage these individuals. Some of it comes under the remit of the fact that there is maybe inadequate evidence to support mild OSA with comorbidities, but there's increasing evidence now to show that mild OSA, hypertension are associated, and treating mild OSA does reduce comorbidities in that aspect. And also increasingly, the impact that it has on sleep quality and people's performance is progressively getting accumulated. So what we're really talking about is treating this segment of the population, which often does not have any proven efficacy-based therapy options. And this is what I call the lost tribe. These are the individuals who will always come to sleep clinics. They will have a sleep study, and we'll often pat them in the back and say, don't worry, you haven't got sleep apnea, you've got nothing to worry about. But actually, we haven't addressed the individual's primary concern of why they're there. They're there because they've got this snoring issue, it affects their sleep quality, and they want some form of therapy options available to them. So why is it that we have an issue in the first place? So these individuals who've got sleep disorder breathing, whether it's mild, moderate, or severe, have no issues with their airway when they're awake. You can lie them down. They have no issues with their airway. However, as soon as they seem to transition into sleep, the airway physiology changes. And these are normal changes that we wouldn't anticipate, which is as evident here, which cortical stimulation reduces, the chemical drive changes, there's lung volume VQ mismatches, and the upper airway becomes inactive or reduced activity. And there's a significant increase in the resistance as well of the upper and the lower airways. Now, most people seem to manage fairly well with these physiological changes and seem to have no significant impact on the quality of sleep or lead to sleep disorder breathing. So there is something additionality that tends to happen, which invariably tips these individuals into a pathophysiological process, what we call sleep disorder breathing, obstructive sleep apnea. And these fall into these three major categories as we understand them right now. We know that an abnormal anatomical airway or a compromised airway is a common denominator for all of these individuals. However, that in isolation is not enough to create the problem, because you could have 10 people with the same anatomical airway and only 4 of them have obstructive sleep apnea, and the other 6 don't seem to have the problem, even though anatomically they have the same compromised airway as individuals who have sleep disorder breathing. Coming from a surgical background, I spend a lot of my time manipulating the airway, making the airway bigger, and it always made me think, what are we really trying to achieve here? So the other aspects which are really crucial is the fact that there are these pathological processes, the unstable ventrally control or the high loop gain, the abnormal arousal threshold. So these people tend to get aroused at very minimal change in physiological indices, which gives them these recurrent awakenings through the night, and hence the consequence related to sleep disorder breathing. A high loop gain is where you have individuals who overcompensate for small changes, resulting in then a overcompensated state of non-responsiveness, and they cycle in and out of overreactivity and underactivity. And lastly, the area that we're really going to talk about today, which is what we are really trying to address with this new device, is this concept of the fact that the upper airway becomes non-responsive to dilatory function, whether that is neural or that's biochemical. It seems to stop responding to the neural drive and tends to collapse, which then leads to the airway obstruction. We know that this loss of tone is most significant in the tongue relative to the other airway muscles. So if you look at pharyngeal dilators, you look at intercostal muscles, you look at the diaphragm, they all lose some neural activity during sleep, but the muscle that greatest loses the neural activity is the tongue. And the tongue is the biggest dilatory muscle in the upper airway, and when that loses its responsiveness, it tends to collapse backwards and obstruct the airway, which tends to be a common pathway for a lot of individual sleep disorder breathing. And that's obvious because if you look at past CPAP, all other modalities of treatment are currently based at the tongue. So if you look at the hypoglossal nerve stimulator, you look at the mandibular advancement devices, you look at surgical interventions other than palatal surgery, they're all looking at maximizing the airway at the oral cavity, tongue base level, because that is a significant contributor to the airway obstruction. What has also been known for quite some time is that the airway behaves very differently in these individuals versus normal simple snorers. There is a progression of a collapsibility of the airway during sleep that transitions from normal to obstructive sleep apnea. So normal individuals, to create a collapse of the upper airway, or P-crit, the critical pressure required for the airway to collapse, is often a negative airway. So you need to create negative luminal pressure to be able to collapse the airway in a normal individual. Patients who have obstructive sleep apnea airway will collapse at positive airway pressures. So there is an integral collapsibility of that airway occurring, and then there is a transition between the different stages of the condition from normal to obstructive sleep apnea. Now, what is very interesting, and that comes back to, we've known this for over 20 to 25 years, is that if you then change the activity of the upper airway, you make it rather than being a passive airway to an active airway, this whole graph shifts from the right to the left, in that you change from needing somebody who can collapse at positive airway pressures, requiring negative airway pressures in a much more stable airway by creating a more active upper airway. That moves the whole graph towards the right index. That's what we're going to be exploiting with the device that we're currently looking at. So it's actually trying to make the upper airway more responsive, more active, so we can shift this graph from the right to the left. So how do we plan to achieve this? Now, if you think you've invented something new, I think you've probably not gone back in history long enough, is usually the answer. Whenever I thought I'd created a new surgical procedure, go far enough in history, people have done it in the past. And hence there is always the knowledge base there. And we've actually used the knowledge base that already exists in the use of neuromuscular electrical stimulation in rehabilitation in locomotor disorders, or also neurological disorders, which has existed for over 25 years. And I just share with you here is just a summary of the metabolic and structural changes where people have used for a long time neuromuscular electrical stimulation for rehabilitation basis. Now, in particular, this article itself looks at all forms of neuromuscular electrical stimulation. In particular, we are using a particular frequency range, which has a very specific change in physiology of the muscle functionality. Now, the advantage we have is that skeletal muscle, as we know it in the limbs, lower limbs, which is the commonest place for it to be used, and the tongue is actually the same. The tongue is skeletal muscle. Now, once you go past the tongue and go into the pharyngeal muscle or the upper esophageal muscle in particular, that's smooth muscle. That's a different muscle type and behaves and reacts differently, but the tongue behaves the same as your lower limb muscle will do. And when you use this low frequency stimulation in these individuals, the data from multiple assessments shows that these are the specific changes that you establish in the muscle functionality. These are important ones. The first one is that you tend to increase the type 1 to type 2A muscle fiber types from a type 2B predominance. You also change the behavior, the enzymatic behavior of the muscle to make them oxidative and glycolytic enzymes. So they're changing the muscle behavior pattern. And the key aspect, because I always got very confused about type 1, type 2, type fast twitch, slow twitch, what means what, but put it into a very simple terminology. Type 2B fibers are basically your bodybuilders. So these are the guys who can pick up, have a high twitch force. They can create a lot of force, but they can't sustain it for very long. And these are the fast-acting muscle fibers, type 2B. There is a lot of evidence to support that with aging, and quite specifically with obstructive sleep apnea, there is progressively increased degree of type 2 fibers in the upper airway, whether it's the tongue, whether it's the palate, or whether it's the pharyngeal muscles. They all show an increased propensity for type 2B type of fibers. What the type 2B fibers do, they can generate strong force, but they can't sustain it, which is why they tend to collapse much more readily through repeated episodes through the night. Type 1, type 2, on the other hand, are medium or small twitch force. So they don't create a lot of force, but what they do have is a lot of resistance to fatigability. And the fatigability of the tongue muscles or the pharyngeal or the oropharyngeal muscles is considered one of the pathological processes that may be leading to the upper airway responsive, lack of upper airway responsiveness and collapse. So we're taking this technology and we're using it in the oral cavity in an innovative manner to get these physiological changes. That's the concept and foundation of where this product comes from. Now, there's a few things I want to just be sure that we have no misconcept, because when we talk about neuromuscular electrical stimulation or electrical stimulation of the upper airway and sleep disorder breathing, people automatically consider hypoglossal nerve stimulators. And how hypoglossal nerve stimulators work and how we're working are entirely different. So what we've got is obviously hypoglossal is much more invasive. You need an implanted device. You may need sensors in the airway as well as the chest. And that essentially is leading to the same therapy as what CPAP is doing. So why is this a change in paradigm? Why is this a different way of looking and working here? The change is that most of the therapy options we have been considering to date are anatomical splints, whether it is CPAP, which is a pneumatic splint, whether it's a mandibular advancement device, which is a physical splint pulling the tongue forward, leading to an increased airway process, or whether it is a hypoglossal nerve stimulator, which activates during an obstructive event, leads to contraction, opens up the airway. All of these are different ways of opening up the airway during sleep and only addressing the endpoint, which is the collapsed airway. What we're trying to do in a non-invasive manner is actually try and treat the core cause or one of the core causes of the airway obstruction, which is the non-responsive upper airway and the change in the physiology of the function of the upper airway, to achieve a more sustainable and true change in therapy of what we're trying to achieve here. So what we're doing is completely different to what is done with the implanted device that you're more aware of nowadays. So I mentioned these are the three major therapy options that are existent. Surgery is obviously one of them, trying to create the airway bigger so that even if it collapses. But one thing we've got to be aware, all of these are anatomical splints. They're not physiological therapies. You stop using the neuromuscular stimulator, you stop using the CPAP, your problem comes back. When it comes to mild to moderate, the only the option that has greatest degree of efficacy is undoubtedly the mandibular advancement device, which is another anatomical splint. But when you come down to the other end, you have a whole gamut of therapy options which have very limited data and efficacy to support them. And unfortunately, people tend to spend, waste a lot of resources on this end and need a sense of direction and products that are going to be efficacious here. So this is where our product comes in. So the product is a three-piece device. So you have a mouthpiece, which is a conductive, so the gray pads are electrodes. And these are conductive silicone, which are encased in a non-conductive silicone. The advantage of this is that this product then has a flexibility in three different dimensions, X, Y, and Z, and that allows it to be a single mouthpiece fits all. So this was something that we developed in conjunction with the maxillofacial department in our department. And this is the product as we see it. And because it's all silicone, it has flexibility and it can expand into three directions. So you can in and out depending on the size. If you have a larger tongue, because you have expansional processes, these electrodes can move away. And then you always have the Z-axis as well, in that it can stretch that way if there is an increased size. So the key thing is it's a one size fits all. You don't have to actually create a bespoke product for each individual to be able to use. There is no fixation, so it doesn't have to be fixed to any part of the oral cavity. It sits and hugs the tongue spontaneously and functions in that manner. Lack of fixation means if you're edentulous or you have some dental issues, it does not matter. You can still use the product. So that's the mouthpiece in itself, which then communicates with this USB with the brains of the product, which is the control unit. The control unit is a rechargeable product which has all the electrics in it and the Bluetooth connectivity, which then connects with a smart app on a smartphone app, which then drives the product. Simply, you put the two together. The minute you put these two together, the product gets activated. You put the product into the mouth as shown with two electrodes above and the two electrodes below, and then the therapy will spontaneously start, run for 20 minutes. The end user can control the intensity of the product so that they try and get the maximal stimulation that they can feel to get the contraction. And then you use the product for 20 minutes, 6 weeks a day to get the desired improvement. Remember, this is not an anatomical split, so it doesn't work straight away. We are looking for a physiological change, and it's a bit like going to the gym. Now, you go to the gym, you're not going to suddenly become super fit after the first session. It takes 4 to 6 weeks of regular therapy and perseverance for you to create the change in your physiology, which is exactly what we're trying to achieve here. And the key things we're trying to do here is we're trying to create athletes versus bodybuilders. If you have that concept in your mind, we're not trying to increase the strength of the tongue. We're actually trying to improve its endurance, reactivity, and performance. So when you see, if you look at, this was our clinical coordinate, you can see that the way the contraction occurs is very different to how you would contract the tongue in a voluntary manner. And this has 6 seconds of contractions, 4 seconds of break. So it's a bit like interval training as you may do in the gym, but we know physiologically it allows the muscle to recover and ensures oxidative exercise. But you can see the kind of contraction is occurring is not something that you would normally be able to create yourself. It is very much based on this kind of frequency therapy. So the plan, the concept here is you've got somebody who's got a compromised airway due to the collapse of the tongue due to its non-responsive nature. We give them daytime therapy, we change the performance of the tongue, so we reduce the collapse. The key thing is these individuals don't wear anything at night with this therapy. The therapy is entirely daytime and they sleep without a product on them or in them at night. So why do we think this concept should work? And there is a lot of literature there, but the key one that I'd like to point out to you, which I'm going to come back to, is this trial that was done with David Wyatt and Atul Malhotra at the Harvard Institute. And they looked at all the different sensorimotor function of the upper airway and tried to identify which process is related to obstructive sleep apnea. And the key factor, the only key factor they found that was associated with obstructive sleep apnea was the fact that obstructive sleep apnea, the tongue can actually generate force higher than normal individuals who don't have sleep apnea. So it's not a lack of strength that is a problem, but they have a significantly lower endurance related to their tongue function. So if you are to generate the maximal tongue pressure, they will outplay any person who doesn't have sleep apnea. But if you ask them to sustain 50% of that maximal pressure for as long as they can, they're substantially poorer than the controls or non-obstructive people are. So the key aspect is the functionality that reflects the pathophysiology we're looking at is lack of endurance. And we'll come back to this. Now, there has been a lot of coverage related to oropharyngeal exercises, which are called myofunctional therapy. And obviously, the Sao Paulo, the Brazilian group really put this on the map, where they have used certain particular forms of exercises and shown that there is a change, as is evident by this graph here on the left, between the controls and the therapy group in a prospective manner, where there is a significant improvement in the airway obstruction or reduction in airway obstruction with the use of these muscle myofunctional therapy. As I demonstrated to you in the previous small video, is that what we're doing is quite different to myofunctional therapy. Myofunctional therapy is voluntary therapy. It works in a different way to what we're trying to achieve. We have a very different physiological function, as I've alluded to previously. So this was our first generation product, which was our prototype, where we did our first trials, which I'd like to just introduce you to as to what we've done. So let's check. Okay, I'm getting there. And at that stage, we really had a flexible PCB encased in a silicone with a different shape, and we used to drive the product with a remote control rather than a smart app. This product was first trialed by my colleague Boris Stuck, who is based in Germany. He's very well known in the European Association of Sleep Medicine, and he kindly did our first trial with 30 patients, whereby we looked at really subjective indices to see, does this product lead to any significant change in patient-reported snoring? And we did the sleep study for inclusion criteria. We had 2 weeks of recording of their partner's visual analog scale, PSQI, ESS, 6 weeks of therapy at that time with twice daily. And then we repeated and we measured their side effects and also the visual analog scale and compared that to the pre-therapy, and also asked them to stop using the device for 2 weeks afterwards to see if there is a hangover effect related to this. So this was the 30-patient trial that we did, and you can see the dark blue is essentially the visual analog scales of the snoring scores before, and the light, the green is their scores afterwards. And in summary, basically the visual analog scale with the therapy dropped from 6.4 to 3.1, which was statistically significant. And this was just some sleep study data of the snoring that you can see in one of these patients through the night, and then that was the post-therapy kind of snoring. So you're never ever going to get rid of the snoring entirely, but there is a substantial reduction, as is evident by that graph showing the pre and post-therapy sleep studies. So that gave us the concept that, yes, this is doing some physiological change in the upper airway. We definitely have an improvement in sleep, in snoring aspect of the sleep disorder breathing. When we then looked at, was there any differences in individuals who were primary snorers, in other words, AHR less than 5, versus those who had mild sleep apnea, there appeared to be no difference at all. So that gave us the confidence to feel that this is a product that can be used not only for primary snoring, but actually treatment of mild sleep apnea as well. So we then went on to do a much more extensive device, having learned from the original product, created a much better user-friendly product run simply by a smartphone device for our next trial, which was then undertaken by our colleagues in London. Big Kotecha was the lead physician there, but we had a multi-center trial that involved 2 Spanish units as well in Pamplona and Valencia, and we had 115 patients in that trial, 65 of which had mild obstructive sleep apnea with an apnea-hypopnea index of 15. The protocol was similar with quite significant additions. So the first addition was we did very detailed clinical examination, including endoscopy findings, to see if you could identify any particular indices that would be associated with a positive or negative result. We then used objective data, and rather than just use a one-night sleep study, we did 2 consecutive night sleep studies before, 2 consecutive night sleep studies afterwards, to get objective data of both the respiratory indices, in other words, AHI, ODI, saturations, but also the sleep snoring sound. And we use the watchpad. The watchpad has the advantage that the sound recording is fixed to the suprasternal notch, which is a fairly regular distance from the mouth. So we know that there are issues related to suspended sound recordings in sleep labs can be really challenging, but this has been a validated way of recording sound. So we now have a way of measuring both objectively, both the sound of snoring, but also the sleep indices. So this was the demographics, predominantly men, as you would anticipate. Mean age was 47, which is, as you would expect. So our inclusion criteria was AHR less than 35. And the range, as is evident, was from 21 to 38. So what did we find in this group of our patients? So what we found, was, just move this image to the side. What we found was that when we looked at the AHI, the average AHI in this group dropped from 10.39 to 4.95. So it is about 50% reduction in AHI, about 50% reduction in ODI, and with it, a substantial 3-point reduction in Epworth Sleepiness Score, which is quite high a change, as would be is surprising. There's a lot of CPAP, 2 index change is considered to be significant and positive. So what the other thing we found was that 79% of our individuals showed a change in AHI or ODI. So in about 20% of people, we will not get any significant change in these indices. And that kind of concurs through a lot of our clinical trials. It's 80% seem to respond, 20% don't seem to get any effect. There seems to be a 50% reduction in the respiratory indices, and about 30% of them would be considered cured in that they have more than 50% reduction with an AHI below 5. That's considered the criteria, sheer criteria for cures with obstructive sleep apnea. So 30% of them would be considered to have been cured. When we looked at their snoring sound, we looked at all snoring sound above 40 decibels as an indication, and this was the kind of distribution we got, and as is evident here, there was 90% of individuals showed some change in their snoring with this device. And that's objective change in percentage of time that these individuals are snoring through the night. The average reduction, once again, seems to be about 54–55%, and with about more than 70 of the patients, 70% of the people showing more than 50% reduction in their snoring sound. So it's clearly evidence to support that there is a change in the dynamics and the flow rates in the upper airway related to this device. So this was the 115 patient data with 65 with mild obstructive sleep apnea. Now, the side effects associated with this was the main one really was excessive salivation, and about 12% or 10%, you'd say, if it's 12 out of 115. And this really was predominantly evident within the first week of use of the product. So the blue line here is excessive salivation, and you can see that although 12 individuals described it in the first week, as you go down through the weeks, the side effect profile significantly reduces. And that's not uncommon with any device that's used in the oral cavity. All of these side effects were only evident during the time of the use. None of them was maintained subsequent to the 20-minute therapy time. So most of these, as you can see, are well, they're obviously transient and are minor side effects. So there were no major side effects associated with our product. So the product's being used with people with titanium implants, with caps and fillings with no significant impact. You can see that there is some filling sensitivity and some people were getting some discomfort associated with a few. All it required was them to move the product in their mouth, and that disappeared. All the energy is directed inwards towards the tongue. None of it goes laterally. So what we've now also done in this group of 115 patients, we are following them up for further studies and leaving them with the product and letting them behave as they would like to with the product. So we're looking at users and non-users. The way we know that we have users and non-users is because it's a smartphone app, we have complete impression of their compliance. So every time they use the product, we know that the product has been used by this individual. So we can measure their compliance remotely, indefinitely, which is how we did it through the trial, and this is how we're doing it with this follow-up. So these are the individuals who agreed to continue with the trial, with having further sleep studies done at 3 and 6 months, and this is the 6-month data. So what is interesting on the left-hand side is this is the kind, so the percentage, the average percentage of these individuals snoring dropped from about 27, 28 to about 15% through the trial process. If they continued using the device, that was sustained with a 6-month result of about 17%. But if they stopped using the device, there is a progressive migration back towards the status that they were before. What is interesting is a lot of them still had sustained improvement for some time, up to 3 to 6 months, despite the fact that they stopped using the device. So there is a significant hangover effect with it. When we looked at the AHI and the ODI specifically, that if they stop using the device, there's a dramatic difference in what happens to them. So this was the change in AHI that you can see from 10 to, in this group, the AHI dropped to 8. As we know, the whole group, there was a significantly greater drop. But if they stop using the product, they migrate back to the AHI they had before. If they continue using the product, it appears that the AHI progressively reduces over time. So there is a continual physiological process happening with the use of the device, with a progressive improvement in responsiveness that is occurring in these individuals. And the same kind of response we saw in the individuals with ODI as well. So it does have long-term sustainable improvements related to this product. So what we also did was we engaged with Atul Malhotra, who's based at UCSD. He's probably published most prolifically in this area. And we really approached him with a view to getting some mechanistic data of understanding what is our product doing. And they did a trial on 20 patients with PSG before and PSG after. And this is the group that we're going to just look at with the age distribution and the BMI, very similar to our group that we saw. They looked at those physiological changes that we discussed earlier on. So we're looking at not only AHI, but the functionality of the tongue. So in the mild sleep apnea group of this, the AHI dropped from 19.7 to 8.4. You'll say, well, how come mild sleep apnea, you got an AHI of 19.7? So what happened was the inclusion criteria was using home sleep study, and then they had a PSG before and a PSG after. Now, as we are aware that HST sometimes in the mild segment is a little bit unreliable. So when the PSG data came out, some of them had quite significantly higher AHI above 50. So a group of them were actually moderate to severe sleep apneics in this group. And you can see what happened to the AHI, even though they were in the moderate to severe group, there's a substantial reduction in that. And then we had the moderate group lower down, which shows those changes that we have seen before. But overall, in the 12 patients who had mild sleep apnea, you can see there was a substantial reduction of about 50% again in their AHI. When we looked particularly at the tongue physiology, what they noted is that there was a substantial increase in the tongue endurance assessment. So this shows the tongue endurance goes from 21.7 to 36.9, and you will see that almost all the individuals show change, and there are some who show minimal change or a reverse, or don't show any significant improvement in the endurance. And that is a substantial improvement to underpin as to how the product is working. It's working by changing the functionality of the tongue muscle. When you look at the maximal protrusion force, which we know is already elevated in people with sleep disorder breathing, there was no change. And that is great, because we're not trying to create bodybuilders, we're trying to create athletes, marathon runners who can actually have a sustainable performance through the night when the whole neural drive to the tongue and the responsiveness of the tongue drops. We need a muscle fiber type that can actually have a higher endurance. So this mechanistic data is very supportive of that change that we're actually looking at. We feel that this supports the mechanism that we believe our product is working with. So just to summarize, I think what we bring to you is a completely different paradigm of treatment of sleep disorder breathing. This is a shift from a nighttime variable airway splint mechanism to a physiological change in the causation of obstructive sleep apnea. The advantages we have: low burden of use for the patient, because it's 20 minutes once a day during the wakeful state. They don't have to wear anything at night. After 6 weeks, a maintenance therapy is once or twice weekly on a long-term basis. You stop using it, eventually you will migrate back to the way you were before, just the way the muscle physiology works. The key thing is it's one size fits all. So you can pick this product off the shelf, give it to the patient in front of you. You need no specific bespoke fixation related to it. And I think one thing we have looked at, the data we present shows really a high level of efficacy, and we feel we have a role in the management of sleep disorder breathing and primary snoring. So with what I like to do is at this point just give you an opportunity to maybe have a discussion, ask any questions, question anything I may have put forward before, or challenge some of the thought process that I present. So I'm still in control, so I should be able to unmute all.
Yeah.
How do I do that?
So I think as people have questions, they can even just hit the space bar and unmute there as well, but that's a fan.
Yep. So I think everybody can unmute themselves now.
Everybody
if they wish to ask a question.
Should be able to unmute now and discuss. So fantastic talk. I know I have lots of questions. I'll see if anybody else wants to ask anything first before jumping in. But thank you so much for that. I think Dr. Awad Senior, you're muted there, so you'll have to unmute yourself. hold the space bar while you're asking your question. So in the meantime, while that gets sorted, I'll ask. So in terms of the physiologic function, I know that you've now, with Dr. Malhotra, with Atul, you guys have done some of the physiologic study. Did you do EMG in those studies? Is that how you were looking at tongue function?
No, we've looked at tongue function both with EMG and with daytime functionality. So that is daytime functionality to check it. So the EMG data is currently being assessed because there are two phases to it, tonic and phasic phases. The EMG is a very complex process to really to assess. So Atul is still looking at the EMG data related to this trial, but the physiological data has come out. The other data is out already, which is why we're sharing it with you.
And the question, I have a number from this. It's a very interesting topic that we can talk about really at quite extensive lengths. But which muscles do you think that the device is actually aiming to stimulate is the one that I'm sort of having trouble deciphering? Is it the genioglossus that you think
So definitely the genioglossus, and we know that because I haven't shared with you, but I'll put the slide in next time where you can see me using the device with electrodes in my neck. But essentially, we've done a trial of 10 people where we actually got them to use the device, and we did ultrasound-guided EMG to assess the genioglossus, and you can show with the EMG that the genioglossus has been activated with the electrical stimulation during therapy. So we know we're doing genioglossus, but with the positioning of what we've got, we know that we will also be hitting the intrinsic muscles of the tongue, and yet usually we don't give much emphasis to the intrinsic muscles, but actually they form a significant proportion of the tongue mass. And yes, genioglossus has been extensively studied, and yes, genioglossus is probably one of the strongest protrusion muscles of the tongue, but the tongue really has a substantial other muscles which are also assisting. So when it comes to things like palatal glossus, which is also known to be a dilatory muscle, it's more difficult to do EMG studies on that, and it involves a very different intraoral EMG. So we don't know, but we know that we're definitely treating the genioglossus, and we're treating the intrinsic muscles of the tongue. It's likely we're treating some of the extrinsic muscles as well.
Yeah, there's this concept, and I'm sure you've come across it in the neurostim literature about palatal glossus coupling. And I do wonder if that is one of the potential indicators for success in your patient population as well, where they've seen that patients who demonstrate coupling of the palatal glossus, for those who are unfamiliar, that muscle that sits in the pharyngeal airway, when you push the tongue forward, you see stimulation of the palatal glossus muscle at the same time. In some patients, and those patients have been shown to be more likely to benefit from a device called an upper airway stimulator or an implant for sleep apnea, which stimulates the tongue. So I do wonder if that relationship may exist. But there's one question here I see from Dr. Soparkar, which is anticipated cost of this therapy.
So that's geographical difference. I think there is a cost structure already there. Cami, do you have the cost structure for Canada?
Because I know we were still talking about this, but I'll let Cami jump in. We were still discussing this.
Yeah, Matt, are you there? I'm just gonna maybe pass that one off to
Matt. Matt's there as well. Sorry.
Yeah, we were just earlier on a call talking about it.
Yes, so the cost to the consumer is 1,000 Canadian.
Okay. And I guess the big question for us from the Ontario healthcare system is looking at whether or not we're going to be able to get extended health benefits coverage for this. And I think that's something that, we'll be happy to help explore to some degree. We're going to at least try for a subset of patients and see what we come back with as you continue to, essentially build out the evidence that we can submit to those insurers to aim for reimbursement.
Absolutely. I think that's the way we have to move. And obviously we need to continue accumulating evidence to support the product, and then we would really appreciate the support of yourself and other clinicians to say this is a product that is has a position, this is a product that is beneficial for our patients, and that's the only way we're going to get this reimbursement process moving forward. It's going to be a slow process, but I think we feel confident we should be able to get there.
I have a question regarding you followed up the patient for 6 months. Is that the longest period of time you followed the patient up until now?
Up to now, 6 months is the longest we've got, and the plan is to continue monitoring these individuals for up to a year. So we're going to continue accumulating data as we go.
And what about compliance rate? Like what?
So we can monitor their compliance remotely, so we know exactly what the compliance of these individuals are. And part of the reason we want to do that is we're going to create a platform on the smartphone for the patient to have control of what is happening. So the platform will give the patient a complete history of their utilization, the change in their snoring sound, but also will give them nudges if they've not used the product for a couple of days and they're in the 6-week therapy period. So we're making sure that compliance remains a significant issue, but the compliance in our trial was 63.5%, something along those lines. Interestingly, when we looked at the compliance versus outcome, there wasn't really any significant correlation. So some people seem to get away with lower therapy modalities and others need slightly higher.
The compliance was about
If I might, sorry.
63%
Sorry.
during the trial, but what about after the trial?
So as you can see that we let the individuals do what they want to do, and we are monitoring what they, so we called non-users are individuals who use the product for less. So maintenance therapy after 6 weeks is once or twice weekly. Okay. So we recommend twice weekly for mild OSA, once weekly for primary snoring. Anybody whose weekly compliance was less than 0.5 was considered a non-user. Anybody's compliance that was about 1 was considered a user. So there's 2 charts I'm showing. The non-users were those who were using it less than 0.5% per week, and the average utilization of the users was 1.5 or 1.8 per week.
Might we see some data in the near future about NMES as adjunct therapy along with, say, CPAP for people with moderate to severe sleep apnea?
Absolutely.
People who have failed or reduce their pressure requirements.
That's exactly what we were talking about just earlier on. Is we have a current trial happening in London where we're using adjuvant therapy with APAP. So we're looking at APAP utilization, in particular people who are struggling with more than 4 hours of utilization per hour due to high pressures. And we're using this modality of treatment through the day and looking at how the APAP pressures and utilization changes over the subsequent 2 months. So yes, there will be data, and this should be out by hopefully January. We should have the data out on this APAP trial.
Were you able to objectively assess sleep quality or architecture before and after?
Yeah, so we've, because we're using WatchPat, which is a home HST, in that big trial, 115 patients, we could not do sleep quality. RDI, it kind of gives you an RDI, but I think people question WatchPat and RDI, arousals, etc. So we haven't presented that data. We don't want that controversy. But when we looked at the PSG data that Atul looked at, there was a reduction in sleep latency. That was a key difference that we found, was that there was an improvement in sleep latency on the sleep parameters. Now, with the subjective measures, we've looked at ESS and PSQI, both of which have shown a change in all our trials, but those are subjective measures.
About anything about arousal?
The number of arousals did not change between the 2 groups in that 20-patient trial, because remember, that's only 20 patients, and we have to question whether the power that was powered enough to show a change in those areas. It's very much a mechanistic study, small numbers. It's not adequately powered to show statistically differences.
I have, one question in terms of those that you deemed responders, the 80% of responders and the 20% that were found not to be responders. And we have another question here, which I'll read you after. But My question pertains to nasal breathing. So recently I was presenting at the SARC meeting, which I'm sure you're familiar with, the Singapore Allergy and Rhinology group.
Yeah.
And I was presenting on nasal breathing and sleep quality in particular. And really, I think the evidence has existed for a long time, but continues to mount about the importance of nasal breathing in sleep architecture and also in upper airway resistance, primarily for your purposes.
Yeah.
And so I'm curious, given that you're an expert rhinologist, have you noted that in those patients that have been deemed non-responders that they are oral breathers versus nasal breathers?
Well, because we didn't on our sleep studies have specific nasal or oral airflow monitors. What we did have is a endoscopic examination of the upper airway during wake, so it wasn't during sleep or sedation.
Mm-hmm.
And we looked at individuals who may have identified airway obstructions such as septal deviation, turbinate hypertrophy. Also, we did it with Muller maneuver, Eschmarsch maneuver, snoring simulation. And none of these indices really correlated with responders or non-responders. Now, that is not surprising because we know that the upper airway behaves differently during wakefulness and during sleep.
Mm-hmm.
When you go down, the whole nasal physiology changes, your nasal resistance doubles from a vertical to horizontal place, and there are whole physiological changes that occur in the nasal airway. So I think I definitely support your concept that nasal airflow or nasal breathing is crucial to try and have the best opportunity of having a patent airway because of the nasopharyngeal reflexes that exist. And undoubtedly, the minute you open your mouth, you lose the nasopharyngeal reflex, a dilatory effect, but also you have lost the fixation for the lower jaw, and the tongue is much more prone to dropping backwards in that position, and the airway is unstable in that way.
Mm-hmm.
So I agree that nasal breathing is a crucial thing, but we don't have any measures at present for me to be able to say whether there's any difference. We looked at supine versus non-supine, and there's no correlation, and there was no change in their position as a contributory factor to this change improvement that we've seen. Because obviously, if they were less supine in their post-sleep studies, then there would be a chance that this change relates to their positional change. In fact, they spent slightly higher time in supine position in the post-sleep studies than in the pre-studies. So we're quite confident it's not a positional component here.
Great. I did see a question from, I believe it's Dr. Okoli, one of our associate physicians as well, and very experienced sleep specialist. She was asking, because she joined a little bit late, is this device mostly to control snoring or to help with mild OSA? And Cami had mentioned that obviously the device is approved for the use of both mild OSA and snoring, and now you're looking at some of the data on moderate OSA as well.
Absolutely. So I think the key thing we want to do is to be sure about our efficacy. And as we go up, we need to prove the concept at a particular level and then progressively look and explore whether the efficacy goes up into the moderate to severe group as well. We can see some indirect evidence, as you saw with the UCSD trial data, where we did have some individuals with severe and moderate whose AHI drops notably, but that's indirect evidence. We really have to substantiate that change in a proper trial with whole group as an analysis. So we're definitely progressing in there. We want a structured approach to this. We want to get in, we prove the concept, move up to a high level, challenge the product. And I think moderate to severe, definitely we feel confident with moderate. Severe will be a challenge because it's often multifactorial, lots of other things affect it as well.
John, I think you're muted there, but please.
John, you may need to unmute yourself.
Sorry about that.
No
yes, Dr. Sama, a great presentation. Thank you. With regards to what you just said, there's a great interest for us that do oral appliances to use this as adjunctive therapy, as was mentioned, to be able to reduce the pressure used with APAP. So this could be great with helping those folks that have severe sleep apnea, where the appliance is leaving them short of complete resolution, and working adjunctively. Now, there was a question that was asked, and Dr. The gentleman that you mentioned that was doing the research.
Atul Malhotra, yes, Dr.
Malhotra had mentioned that there's sort of like an on-off switch with the genioglossus muscle. Now, the reading I've done on this is that there's more of a dose response. It's not really an on-off switch, because if it's more of a dose response, then the adjunctive argument, I think, holds better. What are your thoughts on that? This was mentioned in the talk that was with Dr. Sestouli
Yes.
at that time. Yes.
Yeah, I think it's a very interesting concept. So one of the reservations that Atul had about that was the fact that, and that's a worry in itself, is that when you use CPAP or a mandibular advancement device, by the virtue of the fact that you splint the airway open, it tends to not de-innovate. The genioglossus becomes dysfunctional. It stops wanting to do anything. It goes lazy, shall we say.
Right.
And hence he's saying is that it'll be difficult to show that where you've got a product that's actually improving muscle activity, that it's going to work better with a product that deactivates the muscle in a way. Yeah, that was his concept that he was putting forward. So I think, as you said, it's not a black and white case. We know that if you use CPAP, that the genioglossus may become inactive, but the minute you withdraw it, it actually takes a little while and becomes active again. We don't know whether the change in muscle physiology or the muscle fiber type will affect this concept in itself. Now, if it reduces the pressure, say for CPAP, it improves the compliance. The other thing we're very keen to explore, and that's where we're going to do an RCT with APAP, is what happens to these individuals when they take the device out halfway through the night or stop the CPAP halfway through the night, because full night compliance is not common in most people who have obstructive sleep apnea. So one has to think about the effective AHI in these individuals. So if you have an AHI of 60 and you use the device for 4 hours out of 8, technically you are compliant, but actually your AHI is only dropped to 30 because for half of the night you're obstructing as you were previously. So yes, during the CPAP utilization of 4 hours, your AHI may be 0, but for the other 4 hours, your AHI drops to 30. So we feel that if we use it as adjuvant, one of the areas that we could significantly improve also is that time periods where the individual is unable to use their primary treatment modality, which may be APAP or maybe mandibular advancement device. So I think there are two ways that this concept may work. One is the physiological change, and the other is the supportive change for the time that the individual is non-compliant with their primary therapy.
I see we have Dr. Kahali with us here as well. I don't know if Dr. Kahali had any thoughts or questions himself. It's great to have such an expert with us as well. But I do see one quick question from Jessica. And Jessica's asking about age of approval. And so what the age of recommendation is, an age range that was used in your study previously.
Yeah, so we use 18 plus, 18 onwards. We haven't done any trials in the adolescence age. We know there is a significant issue, a rising issue in that age group. And I think there's a significant issue with compliance in that age group. But we really have no data in below 18 years of age to be able to support our position in that group. So it's adult population.
Dr. Sama, I'm going to let you off the hook because I know it's getting past 11 o'clock at night, and we really do appreciate your time coming all the way to us. And I'm sure you'll be in the operating theater or otherwise running one of your very busy clinics at, my former alma mater, which we obviously have much fondness for. So thank you so much for your time. And we look forward to learning more about this device and the emerging research and trying it on hands-on for ourselves. I have one here with me, that I'm going to be using myself. So I'm looking forward to that and seeing how I feel after that, and we'll go from there.
Absolutely. There's nothing like using it yourself, Michael, because I think because people often think that electrical stimulation of the tongue must be, whoa, what is happening here? But you can see from that video I showed you, and I think the best thing is personal experience. You put it in your mouth and you feel it, and all you feel is a pulsating. John, did you use one?
I did. I completed the 6 week
6-week therapy. Yeah.
daily. Now, what I haven't done, I'm one of those folks that at the 6 weeks, I haven't been doing the maintenance.
Ah.
So I guess you probably can tell if you look.
Is that because you got the improvement, you got lazy?
Well, it's hard for me to tell, about improvement because I wear an appliance every night. But so it's not like I was going from baseline with a problem to, but certainly it was easy to use. It's comfortable. And it was not an issue. It was during the COVID period. So I was, usually sitting in my computer or something, and so it was very simple to find. My reminder came on, I put it on and took it off before I knew. And it's very, a simple device for a patient to use and adapt to, for sure.
I think that's a crucial message there. Thanks, John, is that it is a very simple device. The burden of use for the end user is very minimal. And the ability to have a higher compliance rate is hence so much better. So I think it'll be a useful. We need multiple modalities of treatment for our patient. We cannot, gone the days that we just hit them all with one single device, the hammer on everything. We need different modalities of treatment so that we can get the best options of treatment, the best outcomes for our patients, so we can actually reduce the comorbidities in the long term. And I think this will be one of those real options for individuals and clinicians to have. Key thing has to be low burden of use, low side effects, so that we don't actually do more harm than good to our patients.
As you say, if all you have is a hammer, everything looks like a nail, and you've given us at least a wrench. So we're looking forward to trying it and seeing how things go. I'm looking forward to the evidence as it comes. Thank you, Dr. Sama. We appreciate your time.
Thank you very much for your invitation. Greatly enjoyed this. Have a good evening. Thank you.
Have a good evening. Thank you.
All the best.